My name is John Donadieu from Paris. I am a pediatric hemato-oncologist, and I am also a statistician or epidemiologist, and I am in charge of the French registry for congenital neutropenia in France. WHIM was not my first interest. I discovered WHIM by random because working on a chronic neutropenia, I've been aware of a patient with what is called in medicine WHIM. And so at this time, I have to work to understand what is this disease. I have been also stimulated by colleagues working on CXCR4. CXCR4 is a chemokine receptor. These colleagues are in Pasteur Institute in Paris. The story for CXCR4, which is very important for WHIM, start in HIV. The story about WHIM starts about 70 years ago. The first publication of a case which has been later considered as WHIM has been issued in 1964 in New England Journal of Medicine. Curiously, the same patient has been published twice in the New England Journal of Medicine by two teams, but that's the life. At this time, it is a curious neutropenia. This case has some characteristic which was found later, and there is both a very profound neutropenia, infection, and also a very, very specific aspect of the bone marrow. This very specific aspect was named later yelokathexis, which is a Greek name, saying that it is a retention of neutrophils in the bone marrow. And so you have a profound neutropenia, yelokathexis, and later, in case report, we observe there is warts, a lot of warts in this group of patients, and of course, infection. And the name of WHIM came up in 90 because they put the W for warts, the H for hypogammaglobulinemia, which is not so major, the I for infection, and the M for yelokathexis. From the American point of view or English point of view, WHIM is bizarre as the name of a disease. But that's the acronym of this disease at this time. In the 90s, the disease was described only on the basis of symptoms and biological elementary pattern. But this story crossed the HIV. The HIV came up and the epidemic started in the 90s, the 80s, and there is many concern at this time. But a very curious feature was observed. Some patients can be infected by HIV and they are not getting sick. We name this group of patients long-term survivor. At the end of the 90s, this group of patients there is an understanding of this very specific pattern of HIV. And at this time, it was identified that there is a gate in the CD4 lymphocyte. And one of these gates, there is two gates, but one gate is CXCR5, and the second gate was named CXCR4. And if you have a loss of function of the gate CXCR4, the people who have this polymorphism are not sick from HIV. And so we have this CXCR4, HIV, we have a disease named WHIM, and in the beginning of the 2000s, a team in New York found that WHIM is related to a very specific mutation of the CXCR4. But contrary to HIV, long-term survivor, this mutation was a gain of function. And so if you have a gain of function of CXCR4, you have the disease named WHIM. That's a story. And then a lot of things has been started with this because in HIV, there is a development of molecules against the CXCR4, so inhibitor of CXCR4, because we try to reproduce what has been observed in long-term survival. And so if we stop the gate of the lymphocyte CD4, we can stop HEV. And so we have some molecules named CXCR4 inhibitor. And when WHIM was described as a gain of function of CXCR4, of course, we try to put these new molecules, the CXCR4 inhibitor, to treat. So it's a very short overview of this story, but my colleagues in Pasteur Institute are working on HEV. And so we meet together when we have a few cases of WHIM to try to put all the things together and to have a better understanding. Of course, the first challenge in WHIM syndrome is to find the diagnosis. Even if the name WHIM is something already defined, so you have this acronym, in the real life, the way to identify such patients are numerous, because we know that even if the patient has some biological anomaly, of course, when we meet somebody, when you meet your patient for the first time, you have not all the story in front of you. You have a part of the story, and some patients may have a lot of warts. Some patients may have infection. Some patients may have a mild neutropenia. And so the symptoms are usually not really specific of WHIM. What became specific is to have this infection, these warts, and also a blood count very specific. And the blood count specific is low neutrophils, but in the same times, low lymphocyte, which is very frequent. And you have hypogammaglobulinemia. So you may have this pattern to make the diagnosis. But at the beginning, the first symptoms are very simple symptoms like infection, like warts. What we have observed looking to the patient is that a lot of these patients have a very specific heart defect, which sometimes has been cured in the neonatal period. The heart defect is a tetralogy of Fallot, so a very specific heart abnormality. Sometimes you see a kid, maybe 10 years old, who have infection and blood test, annual blood test. But when you ask on the medical history, you have this background of tetralogy of Fallot. And if we put all the things together, you have the hypothesis that it can be a WHIM, and you can have the genetic test to confirm this, which is a clear-cut genetic test. If you have this gain of function, there is no doubt it's a WHIM syndrome. With regard to the natural history, I think a patient with WHIM don't feel at the present sick. They feel sick if they have acute infection. They feel sick if they have a cancer, which is threatening for them. But daily, they don't feel sick. And that's a big paradox, because we know that maybe they have a severe infection every 2 years, and between the two severe infections, they don't feel bad. And so we don't want to tell them you are in danger, you are in a compromised situation. So we need to be not diplomatic, but we don't want to get them to get sick in their mind. They have strong mind, but they have to consider that it is somewhere some dangerous situation. And they need to have a good contact with their doctors, not to do too much, but to do a good thing in a good time. In terms of symptoms, the most frequent one is infection. Such patients have bacterial infection. So bacterial infection is pneumonitis. They may have skin infection, like what we call cellulitis, infection of the deep tissue under the skin. And also you may have, after this, and mouth infection, oral infection. And you may have gut infection, you may have arthritis. So profound infection and severe infection. That's the first symptoms. The second symptoms clinically is warts. Warts are not permanent. You may have some flare of warts, but not, I say, not a single wart, but maybe a huge number of warts. Usually we consider warts if you have more than 10 warts in the same time. And if you have these two symptoms, you became in alert. If you have a blood count with less than 500 neutrophil count and lymphocyte with less than 500, it became a strong suspicion of WHIM. I think well, for years we have no solution, and so we try to do the best. Very important to have an early diagnosis. But now we have many solutions to help such patients. So it became important and very clear for the patient to prevent the consequence of repeated infection. For example, such patient may have a recurrent chronic bronchitis, and at the end, they have obstructive bronchitis, which may limit their breath and respiratory capacity. So this is a first group of disease. The second group of disease for which it is important to make the early diagnosis are warts. Again, when we have no solution except to burn the wart, it's not very satisfactory, but now we have better solution for that. The prevention of warts is important because not a single wart, but with time, all this package of warts may transform in cancer, in a kind of in malignancy. And so it became important to make the early diagnosis before the warts turn bad. There is now good reason to protect some life-threatening organs like lungs, also to prevent the possibility of cancer in this group of patients.